This morning we're going to talk about applying principles of education to medical teaching, teaching in medicine. With me are our two faculty development fellows at State University of New York Downstate Medical Center, Department of Family Medicine, Dr. Marie Law Jean-Jacques. Good morning, Marie. And Dr. Bash Iyengar.
Good morning.
Both of them are here to learn about teaching in medicine, as are you. So the first thing that we want to look at is the environment that we deal with and how we mold it to really optimize learning in medicine. Marie, you're on the inpatient service, and what is that like?
When you have a high number of patients, so you have to deal with different attending.
So there's not one way of treating a patient, and when residents have their service attending and maybe 5 or 6 private attendings, they now have 6 bosses, and each of them have different expectations, different ways of doing things. So between your very sick patients and between your large number of patients at times and having so many bosses attendings, I think what we're talking about is not only moderating the stress, getting it to work, creating a structure, but also creating a safety net for patient care. What does that resident or learner do when they've come to the end of the road, when they're afraid? So, stress reaches a point where it becomes dysfunctional. They have a place to go. And that's, I think, really critical anytime you're on an acute care service. Great. Yeah. Bosh, what about you? Now, you're working largely in outpatient,
Right.
Precepting, often with me. What do you think? What are the issues in terms of stress and learning?
There's a big time stressor that's in place, so that's something that we as facilitators have to kind of help our learners kind of manage and budget time.
There is really a relationship between stress and learning. If there's no stress, there's not going to be any learning. There's no structure. People don't have responsibility. On the other hand, if you have patients crashing all around you and you can't control that, you can't organize that, you can't give your learner a place to go, high stress, again, no learning. And if you look at this curve between stress and learning, that's exactly what it says. Low stress, no learning, high stress, no learning. So you've both mentioned some very important techniques that all of us do to create the correct amount of stress and in a way to control it. So you can go in and learn during patient care. Because the interesting thing about medical teaching, and Franz Reichmann says this, is that it's unique to the whole field of education. It's being prepared for the unprepared. We can't decide who's going to walk in. We don't have control over who the patients are, or even to a large extent, how many residents, attendings, PAs will be in our outpatient setting. So, all of us have to look at structured roles. Our learners should know expectations. They should have a place to go when they're in trouble. And by sort of controlling our environment so that if a patient codes, you take control, you organize. So we're creating expectations, we're consistent in our expectations and our supervision, and we're always thinking about having just the right amount of stress. So what is it that we're teaching? Teaching knowledge. But is that enough? We make sure that they have that baseline. And if it's not there, sometimes we'll ask a few questions to give everybody an understanding. But then what are we doing? What are we really teaching? So we're teaching concepts.
Concepts, yeah.
And that's what learners want. They want concepts because the information that's in books and on the computer changes. It changes every day. So we teach our learners how to collect information. And how is it that resident students and young doctors collect information? By doing a what?
History. So
we teach them about the dimensions of illnesses and to find out from the patients what symptoms they have and when things started and what makes them better and what makes them the same. So we teach them how to take a history and collect information. And then what do they go on and do? Physical exam. And we have to make sure our learners really know how to do a physical exam and when to do it. So one of the biggest problems we find with our students is really understanding that if a patient has a headache or a stroke or a seizure, they need to do what kind of an exam?
Neurological.
Yeah. So often they'll know the neurological exam, but they don't know when to apply it. And you kind of have to make those connections for people. And once you do it and they understand why, you make those connections for life. So now we have a learner who's taken a history, they've done their whole physical exam, And this is the toughest part of medicine. What do they have to do now?
They have to make an assessment.
Putting the pieces of the
together.
puzzle together. How is it that we help our learners, our residents and students, to do the most important thing a doctor does? To take the information in the history and to take the data we've gathered in our physical exam and put it all together. What do we do to facilitate putting the pieces together? Thinking out loud for them.
Yeah.
We're saying, hey, we took the fact that the patient had shortness of breath, and we didn't hear breath sounds here on their lung exam, and we're saying, now look at the EKG. Put all the information together. Does this patient have a pneumothorax? We're missing breath sounds, they're short of breath. We're trying to put the signs and symptoms together with laboratory and informational data that we've done, diagnostic data, and come up with a differential diagnosis. Now, for some residents and students, this is second nature. But for others, this sometimes is the most difficult part of learning medicine. And certainly thinking out loud helps. What are some of the other things that you think help? Bosh?
You said, like, hey, what are you thinking? How would you approach that? What do you think about the pathophys of that entity? What do you think is really causing that? And kind of ordering it at the same time as to, like, what's most lethal or what's most harmful and what's the most common too.
So what you're saying essentially is give the learner a chance to problem solve and help guide their thinking. And that can be extremely valuable. And while you're doing it, make sure you prioritize. The patient comes first. So you have to make a place for medical education. You as the teacher, as the faculty development fellow, me as the attending, we all have to be sure that we include education as a part of what we do. And education requires interest. And interest is going to take your time and attention. And when you have so many patients, that's something you really have to pay attention to yourself. You have to make learning a priority. What's better than a patient's human story? What's better than somebody bringing their problems? That same patient that provides that valuable opportunity, that magic moment for education in medicine, is the same element that's taking away your interest. It's that's demanding your attention. That patient and their well-being must come first. But then all of us have this responsibility, right? Is the resident or student the only one we teach as doctors?
No, patient.
The patients we teach. In fact, doctor, docere from Greek, means teacher. So we teach patients, but we've always got to make sure there's room to teach that resident, that fellow, that's medical student, because that's our future in medicine. What is it that we want in our learners? Basic knowledge. People need to understand it, and they need to be able to apply it. How important is that in medicine?
If you don't know the basics, it really becomes a very fruitless proposition.
So that, we do have to discuss, describe, and explain, because our residents, our fellows, our students, our colleagues, when we get up to teach our colleagues, not only need to have that basic knowledge, they need to know when and how to use it, and that becomes important. We need to apply it, but we also need to do an analysis, and that's what you folks see going on at M&M rounds, isn't it? You think it's a bad thing to propose a different way to treat something or a different diagnosis?
No, not at all.
Why not?
Because, first of all, there's no 100% in medicine. We really have to keep a broad, open mind on how we approach it. And if we might have been thinking one thing, because the patient's a dynamic individual.
Is the most important thing that a doctor or provider can do is to question themselves, to be willing to go back, to understand that people are dynamic and their health changes, their attitudes change, their moods change. And this is the kind of thinking, the kind of integration, putting the puzzle together that we have to help our learners to distinguish, to classify, compare and contrast, put information together. And then the last part, you're right, is evaluation. We're always evaluating, always thinking, how have things changed? Right. That, there's a certain amount of security in a situation staying the same, isn't there? And yet, we're in a dynamic area. where diseases can present differently, where we're asking learners to integrate information, where things always seem to be changing. You know, you're getting new patients every day and sending patients home. It's very often difficult for our learners to adjust to these new situations. One of the things we have to do as teachers is allow our learners to be wrong. So you know that often the patient can change their story depending upon their level of fear, their level of comfort. There's always that doorknob diagnosis on the outpatient service.
I said, do you have heartburn? She said, no, I don't have heartburn. And one of the residents told her, so are you taking Nexium? She said, yeah, I've been taking Nexium for the past 2 years. And she said, well, why are you taking Nexium? For heartburn.
Often, patients want us to think the best of them. And of course, no one ever has sex. How we end up with all these children, I'll never know. But no one fesses up to sex in this country. And so much of our diseases that we see are related to people's sexual and personal and social habits. So, you know, I think all of this plays in. And how do you teach this?
Creating a situation where they feel comfortable to learn and ask questions and not be afraid to get things wrong or make mistakes. Because I think that's a powerful thing for learners to do.
So think about how we even choose our articles that we present on a Wednesday morning. We're looking at developing a knowledge base. We're looking at applying that base to the patients on our service. And we're also looking to show our residents and students that treatments change, ideas change, and they change for the better. Because the better, the more molecular, the deeper the understanding we have of a disease, the more we understand about how our treatments work, the better we can predict about how patients will present. What about the questions we ask them?
First thing I ask, what are you thinking? And the next thing I ask is, well, what would you do next?
What would you do next? That's an excellent question. How about if we look at relationships between different things? What would you have predicted in the lab value? What is the lab value? What does that mean? So we're always trying to ask questions that will lead to concepts that get our learners to put the information together. And alternatives, comparing and contrasting. And this, I think this is really critical because here we have on the left the patient who's obviously acutely ill. And on the right, we have the teacher, that's you and I, trying to pull those residents up that hill, getting them to understand. And then we have the poor person in the center, that's us. Because, you know, we're walking this tightrope always. On the one hand, there's the patient, and on the other, there's the learner. And the patient demands so much of our attention that often it seems easy to forget about the education, and we just can't do that. So as you were saying, Bosch, some of the basics are to be on time, and that's especially challenging for a chair. You're always being called here and there, and the fellow goes, but to be on time and come prepared. And if, in fact, we're in a business where education in medicine is being prepared, how is it that we come prepared?
So I look at the inpatient service to see how many patients I have.
Good.
Based on how many patients I have, I see the diagnosis. So at least I have a sense what's waiting for me.
So one thing you're looking at is your patient load, the types of diagnoses, and also you not only want to have an idea of your patients, but also look at the number of learners, the residents you have. Sure. Do we have 2 residents for that session? You know who your senior is on service, your night float, and your 2 juniors. That changes for us every day.
Sure.
And it's not only how many residents, it's what level they're at and who that particular resident is. Each one of your learners has strengths and weaknesses, and you as the teacher must be able to assess that and work with them. Learning begins where the learner is, and that's a real basic. So who's there, what year, how many patients? As you're working with the residents, it's important to keep them as a team, and you're part of the team. The attending is part of the team. You know, we talk about the 4 E's of working with patients: to enlist, engage, be empathetic, and to educate them. How is it that you manage to enlist the residents to get them to work with you?
Meet with them before the session begins. You know, say I'm here, I'm available to you. Whatever you need, you know, just come and ask me.
And I come in and open the door and I say, "Hi, I'm your preceptor for the morning. I'm here to work with you." You let them know who you are. Presumably they already know, but if they don't, you let them know. And you let them know you're here to work with them. How important is that?
I think it's extremely important. I mean, they're people also, you know, they're not machines. So they also want to be accepted and acknowledged and really recognized as they're a functioning part of the team. I think the first thing is to kind of like really just say like hi, the simple things that really go a long way.
You're opening a door,
also,
right?
And also they feel confident. They know they're not alone. They have someone.
That's
with them.
right. That's very important in medicine. That resident is not alone. That resident has somewhere to go, to you, to the attending. That is so critical for patient safety as well as for learning. Because if they feel alone, that stress level shoots up. They're not going to learn. That patient's in danger. There's no safety valve. And in medicine, that's one of the real values of education, is creating that structure that creates patient safety and enhances learning. That's really critical. So one of the things we do is enlist, and when you enlist and say hello, you begin that engagement, don't you? And I'm here to help.
Right.
And we're here to do this together. And that's so important in terms of enlisting and engaging. You know, we separate them out. Now, what about empathy? You know, we talk about empathy with the patient, putting yourself in a patient's position. What about empathy in learning and education? How important is that?
I think it's really important. I think we can't forget like where we came from ourselves. You should try to remember like that we were once in their position, in that shoes, and trying to think of how nervous you were and how many things you have to kind of juggle in the air. So kind of that sense of empathy really goes a long way to kind of really temper things and not make this like a too stressful environment, and say like you need to do this, kind of taking that step back and say like I remember how it was.
You serve a really critical role in the inpatient service because you stand between, you're at the interface of these residents who seem so overwhelmed, they have all this stuff to do with all these sick patients, and the attendings who are also on the spot, and they can be pretty stressed out, and you're in the middle of these two groups. You're a buffer, and you're keeping the communication smooth, you're lowering stress in a stressful situation, you're organizing, and you're serving as a method of a really optimal communication. So you're adjusting your type of teaching to the resident schedule. You're saying, look, they've got 15 patients on the inpatient service. These guys can't sit down with me for an hour and a half.
No.
We're just going to go around, and I'm going to teach a little bit of something about every patient as we see them, and I'm going to be satisfied for that today.
What they did, yeah.
Is there ever a time when you find that there really isn't anything to teach?
Yes, there are times.
Yeah, it can happen. And then what do you do?
Give them encouragement. Say good job. I mean, good. I think you're hitting everything that you're supposed to do. I think you're doing a great job.
Feedback, very important. Different from evaluation, right? Evaluation is summative. It comes at the end. This is how you did. Feedback comes along the way. This is a great job. So you're guiding the learner to let them know along the path how they can do better. How does that facilitate learning?
I think it increases it tremendously because they're part of the process. It's not a passive thing. It's very active.
You notice what's happening along the way. As we're talking about education, look at how we're going back to issues of stress, issues of concepts, issues of feedback. So in a way, our own educational process mirrors the way we care for patients.
Absolutely. Yeah.
Lots of information, all integrated, all working together. What that tells you is that teaching requires interest and knowledge, and that you yourself have to be a learner, because we're growing people who are lifelong learners.
Absolutely.
Let's talk about a prescription. If we were going to look at a prescription for giving information, because we give information all the time, we know a lot of information. Do you give it to your learner all at once? You doing them a favor?
No, you give them in small packets.
That's right. The people can really only understand a limited amount of information. So when you write a prescription for teaching and learning in medicine, remember to limit the information you give. Prioritize our information. Let's put the most important part of it out there first, because that's what our learner is most likely to remember. Emphasize why it's important. Always use it. Apply it to a patient. So if you're going to give your learner, your resident, some information, apply it. Can any of you think of an example of how you've given information and then applied it?
We pick like a certain topic. We might think about just like talk about like kind of medication that we'd give for a diabetic, and say like what's the situation that you'd give it to, for them, how you'd prescribe it, how you think about doing it, and then you do it.
How it's working.
How it's working.
What part of the underlying pathophysiology that went bad in diabetes is this working on?
Exactly.
For example. So you just don't say, okay, go give this patient some metformin. Is that teaching?
No.
It's kind of like army medicine, right?
Right.
We don't want that. This is a patient with diabetes. The blood glucose is out of control. What might you use and why? How does it work? What are the side effects? So to not only just give information, but again, prioritize. This would be important for your patient. Why? What are they on now? What might you give differently? Repetition for emphasis. Again, that's a way to repeat, but using the concept. And whenever you're teaching, be specific, behavioral, measurable. That student's never supposed to walk out and say, oh, Dr. Iyengar is a great doctor, or Dr. Jean-Jacques, she's so wonderful on the inpatient service. That wasn't the point of your teaching. It's nice if they walk away with a favorable impression of you. That's always nice, right? But it's not the goal here. The goal here is to learn, which brings up the interesting question of what is learning? How do people define learning? You can get knowledge, acquire knowledge, and never learn. How do you know when your learner really has learned? What do they change?
Their behavior.
Their behavior. And people have defined learning as changing behaviors. And that's what we're trying to do. Changing behaviors in a way that optimizes how we evaluate and care for patients. Changing behaviors in a way that lead to professionalism, good attitudes, and a kind of total package. What do you think our learners have expectations and our teachers have expectations? Let's talk about first learner expectations. We're going to begin with the learner is, right? So what are some of the expectations of our learners? What do the residents expect of you?
Something to learn something new, or if it's not new, to understand better something, topic they didn't understand.
Help me to understand something that's tough to understand. And that's what students and residents say all the time. You know, Frank Stritter did these surveys back in 1975. Folks have done them since. And time after time, our learners say, you know what? Some of this stuff is hard to understand. Help me understand it. What else do you think our learners want?
To know how to think about an existing thing in a different way and how to really apply it to the patients and things like that. Because they might understand the pathophys of something, but they might not understand how to actually go about diagnosing it, managing it, treating it. I think that those are types of things that they need to transition from some of the book stuff to actually stuff that you see on the floor or in the clinic.
You're saying that your learners want you to give them a chance to collect that information and to problem solve and to prioritize and give them some guidance when but give them that chance, have that patience with them and to really, and that's tough. It's tough for them and it's tough for you because as you said, time is okay. How important is it that both of you can provide competent care as teachers?
It's extremely important. Again, it comes down to modeling. Again, it comes down to confidence. If the learner looks at you and doesn't see a confident or a competent individual, their trust in you definitely diminishes significantly. And what you say to them, doesn't really hold that much weight or water. So I think it's imperative almost to be a competent physician.
What about our students and our residents? You think they're a vulnerable population? We talk about vulnerable populations in medicine. Are they a vulnerable population in medical education?
Absolutely. I think anytime when you have a hierarchical situation, you're definitely going to have a person who's in a vulnerable situation.
Be very mindful of what we say and how we say it because the residents and students feel vulnerable. So we have to watch out for sexual harassment, verbal aggression, disrespectful statements, not only in our own culture, but in the culture from which a resident comes. Think about all the different places in the world our patients come from.
Sure.
Think about our residents. They come from the Caribbean, they come from Africa, they come from Philippines, they come from here, they come from Vietnam. They just come from everywhere. And we're putting them together here, and very often they're without their families. So we are their families. And very often they don't have the kind of social or financial supports that many of us enjoy. And all of that comes into play when you're dealing with them. Personal things that really impact our learners. Are they living in a place that's really habitable? Do they have a social support? And if not, how does the department, how does the residency become their family and their social support? That can be critical.
Right.
And how vulnerable is that resident? How vulnerable is that student? And what responsibility do we have as teachers to not take advantage, to make sure that each and every one of our learners is respected? And that becomes very critical. And what about us? What about us as teachers? You think teachers are vulnerable?
Absolutely.
You bet. You think the chair's vulnerable?
Everyone is there.
Everybody is. Everybody in medicine. You're laughing, right? But everybody in medicine is accountable. There's transference and there's countertransference, right? Mm-hmm. There's anxiety, there's comfort levels, and sometimes the teacher feels like they have this big target on their back. Sure. What do you think that does to stress?
It raises it.
Yeah. And how do we handle it? And I think, this becomes critically important for all of us. Again, we're not going to underemphasize the importance of feedback, providing stability and support whenever possible, letting our learners know at every point what's important and why, how they can do things a little bit better, and what they're doing that's right. Marie, what are you going to do when you're on an inpatient service and you have a particularly tough resident? They're coming on and they have problems. And while we're going to talk about the problem resident later, not everybody has the same level of skill. How are you going to give that resident feedback? Are you going to go to them constantly and say every day, you need to do this better, you need to do this better? What's also something, if you have all this negative feedback, what's a good technique you may want to use?
Say good
Besides
job.
that? Find something they do right.
Well.
Follow them around if you have to. Eventually they're going to do something right, and let them know, hey, that was really good. To give them not a false level of confidence, but to let them know, they can do things right, and yet they're having all these problems. To let them know they do something right. And, a lot of times teachers don't want to give negative feedback, and they kind of put up with it. You don't want to do that. You want to be able to tell your learner is depending upon you to let them know how they can do things better. But it's always helpful to hear that they have done something good. And everybody can do something better. And that's kind of how you have to approach learning and teaching and learning. And let's talk about, we've looked at feedback, but what about evaluation, which we said was summative? What's so important about evaluation? That it be objective, that it be fair, that you use the same criteria for the same level of training each and every time. How often do you think that happens in medicine?
Not as much as it should.
That's right. And that's a really good answer. Not as much as it should. That often a part of our evaluation, especially in clinical medicine, is subjective. We should try to keep it objective and fair, and that really is important. It not only has ethical and academic implications, but it has legal implications. And what do you think would enhance learning? What do you notice we do with the third-year clerkships? Why do we meet with them on the first day?
To orient them, to tell them what their responsibilities are, what their goals are, objectives, and things like that, so they know what's expected of them.
So let them know what they're going to learn, when they're going to learn it, what their responsibilities as an adult learner are, and then also what are the criteria that they will be evaluated by, under? What are those things we're looking for? And this way they can direct their learning activities and their performance, and we'll have that change in behavior. And sometimes just giving the students the criteria is a great help to them in terms of learning. So Bosch, you know, we talked about being on time, and I think you have a CBL group right now.
I do.
Okay, so I think we'll have to kick you out, and I'll finish with Marie Law.
Sounds good.
So it's been great. It's
Thank you
wonderful
very
talking
much.
to you as usual.
Thank you for having me.
And you'll be back for more, don't worry.
Absolutely.
Thanks a lot.
Thank you.
Okay, so we're going to move on. Okay, and lots of what we're going to do is sort of sum up what we've seen. As you know, during faculty meetings, you've often heard me talk to the faculty about the Master Teacher Series and to look at different aspects of teaching to keep faculty thinking about their teaching, because faculty need faculty development. Also, they're the most valuable resource that we have in our medical center. So let's look at what the powerful behaviors are that are practiced by master teachers. You know, we heard Bosch talk about interest and certainly sharing a passion and delight in what you're doing in your teaching, making students feel capable, knowing your students as people, and you talked about that, Marie, focusing on thinking and learning, and never losing track of the big picture. The big picture for you is the patient, and the big picture for you on inpatient service is severity of disease. Would you say?
Yes.
So that unstable patient has to be the one that really comes first. And especially in that setting, but in every setting, to teach what's essential. What people need to learn at that time, because they're all under a tremendous amount of pressure. Before you go on the ward, you
prepare.
You think and you prepare and you rethink. And sometimes do you find yourself running up to the computer before you start rounds?
Yes, you need to be prepared.
To check on your facts, check your performance, and then you mentioned something very important. Looking at the number of patients and looking at the time you have. Where you have a sit-down teaching session, where you might present an article, or where you might go in-depth into a topic like multiple myeloma. We've had several patients on the service with that diagnosis. Or will you make those walk-around rounds where you're just giving pieces of information and making the sort of magic moments in teaching that way? And how do you introduce on an inpatient service basic science topics? You find that difficult?
It's not difficult because when you have to talk about the patient, the diagnosis, sometimes to understand the physiopathology, you have to go back to basic science.
So you use the patient and you bring in the basic science that's relevant and important for them to understand if they're going to understand what's going on with the patient. You ever find yourself saying, "I'm sorry"?
Yes.
Do you ever find yourself saying, "I don't know"? Yeah, that's pretty shocking. Should you be sorry that you don't know?
No. But I go back and read.
That's right. So you're also modeling that lifelong learner for your resident. Or how about, does the resident ever teach you something?
Oh, every day.
That's right. That's how you know you're a good teacher. Your learners will also teach you, and you should let your learner know. You just taught me something. That empowers them. That gives them the self-confidence that they need to really do the job. You teach them medicine is something that you learn for your whole life when you go back and you look things up in front of them. And the first thing, and sometimes this is the thing we miss, and we talked about greeting, the most important thing sometimes you can say to those residents is, "Good morning," and give them a smile. That's important. And, you know, there's lots of ways of saying. You can actually say good morning, which is important. Sometimes you can bring them goodies to eat. I often do that, as do many attendings. Almost always now during M&M rounds.
We have food. Yeah.
We have food. The service attending, we have huge breakfast. And sometimes it doesn't take a lot, just a little, to let people know that you've thought about them. To let them know how great it is to work with them. It's really important if you find yourself going on at the end, sitting back and saying, "Did I answer your question?"
Yes.
Tell me what your question was again, to make sure you've answered it, and to let your residents or learners know how really great this work is. Well, what about the future? We're heading into the future of the virtual doctor and computer technology and telecommunications and robotics. How will that affect our teaching? And I think a lot of what we talked about this morning, stress, teaching concepts, modeling your thinking for a resident, giving your learner time to problem solve, these are timeless concepts. In terms of feedback, we can all do better. The application of information and concepts that we're teaching, and to understand that medicine and people change. And what do you think changes more? People, the human side of medicine, or the science and technology?
The science and technology.
Yeah. The science and technology seems to change day by day, but a lot of what we encounter in people, their emotions, their responses, that seems to go back to Shakespeare and Dante and thousands of years. So people don't seem to come along as quickly or as far as the science and technology. And sometimes, and I think you mentioned it before, that's a problem, is that patients don't understand what's going on, and they can be fearful, and it may give them, sort of become the roadblock to them giving us the information we need to be able to treat them. So let's finish off. What do we want? What kind of a resident do you want to produce when they finish their month on inpatient service? What kind of a medical student do I want when they finish their 6 weeks? We want them to be mature and confident. We want them to have a certain level of competence. We want them to have a sense of maturity and self-awareness, and to have a sense of their own families, to be able to have a sense of community and ethics. It's very interesting that McGill and Berkowitz in Family Medicine back in 1993 said, what we're doing is not quite teaching, but it's also not quite therapy either. The fact that our students, our residents and students that we deal with, our learners in medicine, like us, are living and growing in this profession, that this profession is really a part of their life, and that what we want is a total package. We want a performance-based learner who will be a lifelong learner, who has a certain level of competence and confidence and self-awareness and maturity. And you know what? We're not going to get that from nothing. Part of that comes from the adult learner themselves. People come to the table with a set of knowledge, skills, and attitudes, and we have to help them mature and form. And every time you get on that ward, look at each of your learners, see where they're at, and try and guide them in the direction that they need to be going.
Right.
Any last minute thoughts?
Fine. Good.
Okay, well, I think that this is a pretty good way to begin to think about teaching and learning in medicine. And we may want to turn some of our efforts toward looking a little bit more deeply into feedback, into what to do with the problem learner, and into how our teaching might be a little bit different when we're precepting on an outpatient service. But I really want to thank you.
Thank you.
Your efforts on the inpatient service have been really wonderful. The residents as well as the attendings really appreciate the important role that you've played and how you really enhance the learning and patient care safety on the inpatient service. And I want to thank you for coming this morning to talk about teaching and learning in medicine.
Okay.
So this morning we've talked about teaching and learning in medicine. We've looked at the importance of stress and the role that stress plays. We've also examined what we're teaching and why, and how to teach it. We've looked at the importance of conceptual understanding, of applying these concepts, and then giving our learners a chance to problem solve, guiding their thinking, and thinking out loud for them. Being respectful, providing feedback, limiting the amount of information, and teaching what is essential.